This video is going to cover a number of additional pathologies as we look through especially the lower abdomen in order to better appreciate the normal anatomy. So in this case, we're looking at a case of acute appendicitis in a relatively young female who had presented with right flank pain. So the arrows here are indicating the appendix. So you can see how it's quite large, it's inflamed, and you can also see some contrast enhancement there within the appendix. And so when you're looking at acute appendicitis, it's common for the diameter of the appendix to be greater than 6 millimeters in diameter. It's also common to see wall enhancement, which you see in this image right here. So you can see how the wall is brighter relative to the lumen. And then what's called fat stranding in the surrounding mesenteric fat. So you can see how there's kind of these strands that appear to be extending out from the appendix into the mesenteric fat, and so that's also indicative of acute appendicitis. Here's another example of acute appendicitis. So you can see the appendix is enlarged and inflamed in this case. And then finally, and this one you can see an example of a proximal versus a distal view of the appendix in the same patient. And so here you see that contrast enhancement around the darker lumen, though you also see some enhancement in the more proximal part of the appendix there as well. And so once again, just to reemphasize, appendix greater than 6 millimeters in diameter, an appendicolith, which is what you see over here with that enhancement, a thick enhancing appendiceal wall, which is what you see over here on the right, and then stranding in the adjacent mesenteric fat, which isn't quite as obvious in this view as it was in the previous one. Remember, we talked about gallbladder or gallstones last time in the gallbladder, and although you can see them on standard radiographic views, both X-ray as well as CT, they're much easier to view on ultrasound. So ultrasound is the preferred modality where you can clearly see this highly reflective echogenic focus as well as the acoustic shadowing distal to the site of the stones. So you can see this all is the gallbladder, and then these are the two stones that are easily observed within the lumen of the gallbladder. So same thing in this image. This is another example of gallstones. So I'll give you a second to see if you can identify them. Here they are up here. So you'll notice that there's a number of them, but notice how difficult it is to appreciate them on radiography. So again, that's where gallstones, they're only radio opaque in about 15 to 20% of cases. So that makes ultrasound the preferred modality for identifying gallstones. This is an example of a number of the different types of gallstones, showing you the different shapes, sizes, and colors that they come in. The ones that are starred are pigmented gallstones. The rest of them are all cholesterol gallstones. Here we have an example of a ruptured AAA, or abdominal aortic aneurysm, in a 66-year-old man. He presented with acute left flank pain, and so you can see the extravasation of blood here in this individual. There's another example of a AAA where you get the double lumen, kind of a false lumen here around the aorta. So that double barreling is an indicative sign of a AAA, a ruptured aortic aneurysm. This is a three-dimensional rendering or volume rendering of a CT of a CT angiogram on a patient with a AAA. So you can see the AAA right here, just proximal to the common iliacs, branching off of the abdominal aorta. And this is an example of what we call a soft tissue rim sign. So this is actually a ureteric stone or a kidney stone. And what the comic here is trying to represent is the fact that you frequently will get this enhancing wall or edematous ureteric wall as a result of a kidney stone being stuck in the ureter. Here's an example of what's called the comet tail sign. And so this is a phlebolith that we're looking at. So remember, this is a thrombosis in a vein in the pelvis in this case. And so the comet sign is where it looks like that there's a comet with a tail. And so that tail is indicative of a phlebolith. So I'm going to give you a second to look at this image, and then we'll scroll through a few of the images here in the series just to see if you can identify any abnormal anatomy. So the key here is we're looking at the sigmoid colon coming down here. You'll notice a number of these enhancing outpouchings, and these are, this is an example of diverticulitis. So again, you can see a number of examples of diverticuli in this patient. Here's a number of other ones along the sigmoid colon. All right, so same thing here. I'm going to give you a minute to look at this and see if you can identify what's going on in this patient. And so you'll notice over here, this is going to be where the abnormality is. So if we kind of go back and forth, what happened in this case is this is an example of intussusception. And so this is where a bowel is pulled within another loop of bowel. So effectively what happens is the proximal part of bowel, as you can see in the cartoon down here, is pulled into a more distal loop, and then it's peristalsed forward through it as if it were a bolus of food. And so again, this caricature drawing over here is trying to represent what occurs with intussusception. And then finally, I'll give you a second to look at this. This is a coronal CT scan, and you can hopefully appreciate a fair number of anatomical structures here. You can clearly make out the IVC and the aorta, the pancreas coming across, or it's actually probably part of the jejunum right there. And then this down here is going to be the descending colon, spleen, and then this is the stomach. So notice the stomach is up here in the thorax, so it's gone past the diaphragm. So this is an example of a hiatal hernia. It's actually a really good example of a hiatal hernia.